Respiratory Drugs Lecture. The following are the pulmonary diseases you will want to be familiar with: COPD, asthma, emphysema, chronic bronchitis, tuberculosis, cystic fibrosis, and RSV. The following are respiratory drug treatments: oxygen therapy, respiratory stimulants, bronchodilators, corticosteroids, mucolytics, expectorants, antitussives, and smoking cessation drugs. We will talk about all of these classifications in the following slides. The first one we're going to talk about is oxygen therapy. Oxygen therapy typically treats hypoxia, which is an O2 saturation less than 91%. Some physicians go by 93%. Oxygen therapy must be documented on the medication list. The rate of oxygen flow must be noted. For example, 2 liters per minute. Oxygen is always labeled liters per minute. There must be a written prescription for oxygen, and if you have a Medicare patient, you will need a DME filled out. There are dangers with oxygen therapy. There's a fire danger when oxygen is used because it supports combustion. We need to instruct our patients not to smoke while hooked up to oxygen. Respiratory stimulants. There are 2 main medications used as respiratory stimulants. We have caffeine citrate and theophylline. Caffeine citrate is much more common in treating neonatal apnea. Theophylline is the alternative treatment to neonatal apnea, but is not the first-line treatment due to its toxicities that can be related. There are 2 respiratory drug teams. We have BAM and we have MAL. BAM is our bronchodilators. The B stands for our beta-2 agonists. For example, we have albuterol. A is for our anticholinergics. For example, we have Atrovent. M is for the methylxanthines, which, for example, we have theophylline. Our anti-inflammatory drugs, we have M for the MAL. M stands for mast cell stabilizers. For example, we have cromolyn. The A stands for anti-inflammatory steroids, which all the steroid medications that we use end in SONE, S-O-N-E. And then we have the L, which is the leukotriene inhibitors, which, for example, we have Singulair. Bronchodilators are used in acute respiratory conditions. They relax the smooth muscle in the bronchial tree. They relieve bronchospasms and decrease the work of breathing. They are used in the treatment of asthma and many forms of COPD. Bronchodilator administration is typically by inhalation. We have metered-dose inhalers, often called MDIs. MDIs can be used with a spacer if patients have a hard time inhaling correctly. Often children will use spacers with this medication. Examples of a metered-dose inhaler are albuterol and Atrovent. We also have dry powder inhalers. An example of this would be Spiriva. And then we have small volume nebulizers. An example of this would be a Duoneb. These types of medications create a drug mist that can be inhaled. Bronchodilator types. We have the simple pulmometric and adrenergic drugs. They relax the smooth muscle in the lungs. They increase the vital capacity. They decrease airway resistance. There are 2 different classifications. We have short-acting beta agonists, which are used for acute or also called rescue inhalers. These are used for acute asthma attacks. An example would be albuterol. Then we also have the long-acting beta-agonists, which are used for chronic or maintenance. An example of this would be salmeterol or the Servant discus. How short-acting and long-acting inhalers work. They work by relaxing the rings in the trachea. Sometimes in asthma attacks, these rings will constrict, that smooth muscle in the trachea will constrict. And the bronchioles and bronchus will also constrict. So we'll give the short-acting beta-agonist to relax those rings and that smooth muscle in the trachea so the medication can reach the bronchus and the bronchioles. Then after we've given that short-acting beta-agonist and we get that constriction reduced down, we can then give the long-acting beta-agonist so the constriction doesn't come back. And that long-acting beta-agonist can reach further down into the bronchus and bronchioles to prevent those asthma attacks. Bronchodilators, we have albuterol, which is typically used to treat asthma. We have terbutaline, which is typically used to treat emphysema. And then we have salmeterol, which is used for COPD. Some common side effects of bronchodilators are nervousness, tremor, and dizziness. You will often have cough and throat irritation, especially if they're using their inhalers quite frequently. Cardiac irregularities, and it will cause hypertension. It will also cause an increase in glucose and also a decrease in serum potassium. Bronchodilator types, so the second type, the A and the BAM, is the anticholinergics, which decrease the chemical promoting bronchospasms. Anticholinergics cause a drying of all bodily secretions, and in this case we are drying the pulmonary secretions. This is typically the first-line therapy for COPD. Medications in this class are short-acting and long-acting. Our short-acting is the ipratropium bromide, also called the Atrovent HFA. Sometimes it's used in combination. Then we have the long-acting, which is the tiotropium or the Spiriva. Many patients prefer the Spiriva over the short-acting, mainly because Spiriva only needs to be taken once daily, and the short-actings need to be taken 3 to 4 times a day. A patient who only has to take an inhaler once a day increases the compliance, so we typically will prescribe that for an increase in compliance. Bronchodilator types. We have the xanines that relax the bronchial airways and pulmonary blood vessels. Serum blood levels for toxicity need to be monitored, 20 milliequivalents or under. The most common is theophylline, and we don't widely use this due to its adverse reactions and its requirement of high monitoring. Corticosteroids, so we are starting the mall of our drug categories. Corticosteroids relieve inflammation, reduce swelling, decrease bronchial spasms, and suppress symptoms of asthma and COPD. We use these for long-term treatment or prophylactic treatment. You wouldn't use this in an acute asthma attack. We often use this in conjunction with beta-2 agonists to control asthma. Corticosteroids can be inhaled, and then they can also be intranasal. The inhaled has one name, as you can see, and is the first one listed here, so Pulmicort, Flovent. Advair discus only comes in an inhaled. You have your twist inhaler. So, and then they also come in intranasal. So your Flonase, your Nasonex, your Nasacort, those types of medications, your Rhinocort, are all your intranasal medications. They are typically used, the intranasal is typically used for non-infectious rhinitis. They decrease edema, congestion, and inflammation. They should be taken before the symptoms start. And it is really important with the intranasal medications that patients rinse their mouth, mainly due to the high risk of an oral fungal infection. Patients will often complain also about throat irritation with these medications, so it's also important to drink plenty of fluids. Asthma prophylaxis. So these types of medications are not for acute asthma attacks. They are more maintenance medications than anything. These medications can also be given to treat allergies. There are two classes here, leukotriene inhibitors, which inhibit the leukotrienes production and decrease inflammation. The most common is singular or Montelli class and is in a tablet form. It prevents exercise-induced bronchoconstriction and treatment of chronic asthma. Mast cell stabilizers. Mast cells burst open, releasing a substance that activates the inflammatory response, causing an increased blood flow to the area. They are used to decrease the inflammatory response that is activated by the mast cells. Cromolyn, which is an inhaled type medication, is used for exercise-induced bronchoconstriction. These medications, it is important to remember and remind patients that it takes about 2 to 6 weeks in order to work. So tell your patients to be patient and keep taking the medication consistently. Mucolytics decrease the hypersecretion of and liquefy pulmonary secretions. They break chemical bonds in mucus, lowering viscosity. The common medication in this class is acetylcysteine or Mucomyst is the most common. Typically either in a nebulizer or a solution. It is important if it's in a nebulizer that bronchodilators are given first, about 10 to 15 minutes prior to dilate the bronchioles to get this medication deeper into the lungs. It is also given in a solution that is drank by patients and often mixed with Coke to hide the horrible taste. Some doctors will give this medication to protect renal function, typically most commonly used with dyes for radiology studies, CT scans, or heart catheterizations where we're using a large amount of dye that can potentially hurt the renal function. We will give this medication to protect the kidneys. However, some physicians do not do this because this is not strongly supported by research. Mucolytics are most commonly given to patients with cystic fibrosis. Expectorants help patients cough productively. They increase secretions, they reduce viscosity, and they help expel sputum. It's also important to instruct patients to drink plenty of fluids. The most common medication in this class is guaifenesin, or also called Mucinex or Robitussin. They are used for treatment of upper respiratory tract infections, bronchitis, pharyngitis, or influenza. And we only use this when there's a wet, productive cough. We will not use this if it is a dry cough. Antitussives are used for preventing the cough by depressing the cough center in the medulla. There are two categories. There are the narcotic. The most common antitussive is codeine with guaifenesin or promethazine. Sometimes hydrocodone will be prescribed if there's an allergy or intolerance to codeine. Hydrocodone is not as commonly used due to its sedative effects. There are also non-narcotic options, Tessalon, Desalum, Robitussin DM, and also diphenhydramine or Benadryl. These medications are much more preferred due to their less sedative effects and a decrease in the dependence of these drugs. So here's a little picture on antitussives, expectorants, and mucolytics. So antitussives work in the throat. They reduce coughing. Guaifenesin or Robitussin, which is an expectorant, irritates mucous membranes to release the mucus by creating a productive cough. And then we have our mucolytics, which break the links that bind the mucus together so it can be coughed up. This is used to decrease the incidence of bacterial or viral infections that can grow in the mucus buildup, commonly used in cystic fibrosis patients. Antihistamines. Antihistamines. So a histamine injures or irritates. Histamines are injured or irritated cells. Histamine is an inflammatory agent that brings swelling to the area, which isn't always helpful. So we have the antihistamines that block the histamine 1 receptors. They combat increased capillary permeability or edema, inflammation, itch. There are 2 different categories. The first generation is a systemic, which is diphenhydramine, or also called Benadryl, which has major side effects of drowsiness and is contraindicated when taking sedatives or muscle relaxants. We also have the second generation drugs, which is the fexofenadine or Allegra, cetirizine or Zyrtec, or the loratadine, also called Claritin. These are much more preferred because there is less sedation effect with these medications. Decongestants are used for the symptomatic relief of cold, the common cold or allergies. They constrict blood vessels in the respiratory tract. The 2 most common medications are phenylephrine and pseudoephedrine. These medications need to be purchased behind the counter at the pharmacy, and the patient will need a valid driver's license in order to purchase. Long-term use of nasal sprays and solutions increase the risk of sensitization, which causes a rebound effect, causing symptoms again. The last category we are going to talk about is smoking cessation aids. We have nicotine replacement therapy, which delivers a small dose of nicotine and gradually weans the patient off. Examples are Nicoderm, Nicorette, and Nicotrol. This is the preferred therapy due to less side effects. We also have bupropion, also called Zyban, varenicline, also called Chantix, which works by telling the brain that smoking is not pleasurable. Many patients get very nauseous by the smell of smoke while taking this medication. However, Zyban and Chantix have a severe side effect of suicidal thoughts. Therefore, the nicotine replacement therapy is the first-line therapy.